odontogenic and tumors that are non-odontogenic. So this makes the diagnostics of this area so very complicated because you have to bear in mind that both types of tumors can be found here. And we will start with just basic information about the tumors, about the general information about the tumors. And the benign tumors, of course, they are neoplasms, so it means they keep on growing without its own ability to stop. So they have constant growth potential. So this differentiates tumors from other pathologies that, at least theoretically speaking, they have unlimited growth potential. And the benign ones, they just spread by direct extension, so they do not metastasize. However, once we have a lecture about salivary glands, we can learn that in case of salivary glands, some tumors really also are histologically benign, but they can metastasize, and this is related to pleomorphic adenoma of salivary glands. But in general, they do not metastasize, and histologically, they just tend to resemble tissue of origin. And I'm pretty much sure that you kind of hated your classes in morph, in pathomorphology. I think I can understand why, because it was so many information, so much information, so many pieces of information, and you had to learn all of this. But personally, I would say that when I was a student, I was very fond of morph, because I both liked the information about histologic characteristics of the tumors, as well as macroscopic characteristics. And I must tell you, I must confess that it helped me a lot later when I was studying for my specialty exams in radiology and diagnostic imaging, because a lot of radiological appearances can be explained by the structure and biology of the tumor. So sometimes hamartoma, so the tumors that do not grow, but they are kind of a tumor, they are also included in this category. So clinical features of benign tumors, they just grow slowly, so they do not arise suddenly. When they are found as incidental findings, in many cases the patient will not be able to tell when they started. Patients may tell you when they first noticed that there was, for example, some kind of a swelling. Usually they are just painless, and they are not life-threatening unless they grow in some areas that are vital, and they may compromise, for example, upper respiratory airway, etc. But in general, a benign tumor itself, it should not kill you. And they are usually detected clinically, but of course, diagnostic imaging is mandatory to assess the extent of the tumor, and also to be able to plan the treatment of the tumor. And sometimes one of the signs of benign tumors, of odontogenic Benign tumors, it's absence of a tooth in the dental arch in patients in developing age, and then a tumor is found as an incidental finding. Many tumors have some anatomic predilection, so it means that they are encountered in some specific places. Of course, this is not always 100%. It's not always so sure, because they the rules say one thing, but medicine is not mathematics or physics. So the living organisms, they do not always abide by the rules. And odontogenic lesions usually arise above the mandibular nerve canal, and non-odontogenic lesions can arise both above and below the mandibular nerve canal. And also, when you can see enlargement of the mandibular nerve canal itself, then you can think that there's something growing out of this canal. So when we review the contents of the canal, it's the nerve and its blood vessels, so it's quite possible that the lesion visible inside the canal, it's of vascular or neural origin. So it can be a neuroma, a neurofibroma, a schwannoma. So these are neural tumors, or it can be a hemangioma, so a tumor derived from blood vessels. And then there's also some cartilage in the mandible, so tumors related to cartilage, they are found with higher frequency around the TMJ, or they can also be found sometimes in the midline, in the symphysis of the mandible from embryological remnants. So benign tumors usually enlarge slowly by formation of additional tissue. So it provides the organism time to get used to the presence of such tumor. So the borders of a benign tumor are well limited, well defined, they are relatively smooth, and sometimes they are corticated, so it means that there is this cortical rim around the tumor, just like what I showed you last week regarding cysts. Some tumors may produce some material which is mineralized, so it can be calcifications, it can be pathologic ossifications, and usually if you find any calcified material in a tumor, you will be able to identify it first inside the tumor, in the middle of a tumor, because this is the most mature part of a tumor, and a periphery is immature. So sometimes, especially in case of odontogenic tumors, you will be able to perceive a radiolucent band of soft tissue, so a capsule at the periphery where the calcified product has not formed yet. And this band separates the more mature internal portion from the surrounding normal bone. And lesions which are benign, they can be also completely radiolucent. They can be completely radiopaque, like for example osteoma, and they may be a mixture of radiopaque and radiolucent tissues. So the radiopaque elements inside a tumor, they can both represent residual bone or calcified material produced by the tumor. Some tumors, like ameloblastoma or myxoma, they form septa, and the septa, they represent residual bone, which is trapped inside the tumor that has remodeled into curved septa. And ameloblastoma itself, it's a tumor that does not produce bone on its own. And for example, osteoblastoma, which is rare, it often has internal granular appearance, and it's a radiopaque pattern which is produced by abnormal bone, which is produced by the tumor, but on the other hand, also the name of the tumor means bone producing. And in fact, the tumors which are radiopaque completely or partly, they are sorry guys. They are more characteristic for diagnostic differentials because there are fewer of them, and if something is really homogeneous unilocular radiolucency, it's not very helpful because it can be a lot of different things, also cysts. So definitely anything excised from the head and neck requires verification by histopathology. As a benign tumor continues to grow and press against the neighboring tissues, the results of a presence of this tumor will be also visible in the surrounding bone. So if the growth is slow enough, there will be enough time for the outer cortex to remodel in response to the pressure exerted by the tumor. And this is achieved through simultaneous resorption of bone along inner part of the tumor and the position of the bone on the outer cortex of the periosteum. So in benign tumors, this remodeling process means that the cortex is thinner than usually, but it maintains its integrity. And benign tumors can also displace teeth that are in their vicinity. However, some tumors like ameloblastoma, which is histologically benign but clinically behaves like a malignant tumor, it can also lead to root resorption. Also, ossifying fibroma and central giant cell granuloma, they tend to resorb roots of teeth. Now, we have got classifications of tumors, and one of them is classification of the head and neck tumors of the World Health Organization, published in 2017. And in this classification, you can find different tumors, which are divided into tumors of odontogenic epithelium, tumors composed of primarily ectomesenchyme, so connective tissue, and tumors that are mixed, so they are made of both of these tissues. So, well, like in a book, we will start with like flagship tumor of the head and neck, which is ameloblastoma. But please remember that technically speaking, this is a rare tumor. So if you think about tumors, I would like to underline that in fact the most common tumor of the mandible, it's plasmacytoma. so a malignant tumor made of plasma cells in bone marrow. And in fact, tumors like amyloblastoma, they are not common tumors. Maybe we observe them more commonly because patients are referred to the dental school with complicated problems. So that's why we can find them. But in general population, they are not so very frequent. But still, they can be the so-called incidental findings because for a long time they may just grow in the jaw. Their favorite location is mandible, posterior mandible, and around the mandibular angle. So, well, we can say in a way that there's a lot of tissue, a lot of bone marrow in these areas. Okay, so it's not so much as long bones, etc. But considering maxilla, which is a bone made mostly of air spaces, so in comparison with maxilla, mandible does have a lot of bone marrow. So the amyloblastoma can continue to grow. Someone has mic on. Can you please check if your mics are off? Because I wouldn't like to switch from the presentation to the control panel. So please, everyone, mute your mics. Amyloblastoma is a true neoplasm made of odontogenic epithelium, and this tumor histologically is benign, but it behaves like aggressive tumor because of local invasion. But apart from a variant that may metastasize, it does not metastasize even if locally it grows to large extent. And there are three types of amyloblastoma. It's multicystic, it's unicystic, and it's peripheral. So what does it mean, peripheral? That it's in soft tissues and not in the bone. So we cannot diagnose the peripheral version with X-rays or with cone beam CT. And for that, other diagnostic imaging methods have to be used, like medical CT and MRI, allowing evaluation of soft tissue components. And amyloblastoma is a tumor of adults and middle-aged patients. So peak appearance is reported at around 40. But on the other hand, nowadays, with more and more examinations being taken, I would never say routinely, because according to the guidelines, you need justified indications for every single use of X-rays in diagnostic imaging of humans, but still it's quite frequent that nowadays a lot of radiographs are being taken in patients during or after dental treatment and follow-up. So I think that this is the reason why some lesions become more obvious. They are encountered at earlier stages of life. And the tumors occur mostly in the mandible, but they are also found in the maxilla, and they may extend into maxillary sinus. So it's usually well defined, and it has cortical border which is curved, and the lesions can be either unicystic, so there is one compartment of a tumor which is completely radiolucent, but more typically the tumor is septated, so it has septa, which are remnants of a destroyed bone. They are curved, and the tumor usually has larger compartments in posterior mandible than in the maxilla. So the structure of the tumor is reported as honeycomb when the compartments of the tumor are the loculations are smaller, and soap bubble appears when larger compartments are visible. So this honeycomb appearance, it can also be reported in case of myxoma, and well, myxoma is less frequent than ameloblastoma. So the effects of an ameloblastoma on surrounding tissues, it definitely includes root resorption, but also tooth displacement is possible. Some teeth can be displaced in the apical direction, and this expansion of and thinning of adjacent cortical plate, it leaves the bone like, let's say, an eggshell. So it's very thin, it's very narrow, and the actual perforation of this bone into soft tissues is really a late feature of ameloblastoma. The tumor can cause extension of the ramus, and anterior border of the ramus will not be visible anymore. And here's a case of ameloblastoma, a very large tumor in the right mandible, and here the arrows point to the extension of the tumor. And against the radiolucent background, you can observe a lot of septa inside the tumor. So in fact, what's most important for you as a future doctor is to be able to find out that there is some kind of a lesion, and then decide whether this is malignant or there is or it looks benign, and when to refer your patient for consultation and for further treatment. If it's a benign lesion, you have some time for decision, but if a lesion looks malignant, then you don't have time to decide. You cannot hesitate. You just have to refer your patient quickly for diagnostic imaging, so that the onset of treatment is not delayed. And this is also ameloblastoma, which was confirmed by histopathology, but in fact it's unilocular radiolucency in right mandibular body. And what you can see here in this radiograph, apart from the tumor itself, it's resorption of the roots. So it's not erect, it's not ill-defined, it's well-defined border of a resorption, and I sometimes say it's not an official radiological sign, but I often compare this to something cut by means of scissors or a knife, a sharp knife. When other diagnostic imaging methods are applied, such as CT or MRI, then the content of the tumor is visible, and the content is soft tissue. So as you remember from the previous lecture, in case of cysts, the content of a cyst, it's fluid, more or less dense, but it's a fluid. And in case of ameloblastoma or another tumor of the odontogenic origin, that tumor will be producing appearance of soft tissue inside the tumor in diagnostic imaging studies. And in case of contrast enhancement, a cyst will enhance only on the periphery, and the tumor will also enhance inside. Well, the benign tumors are not so very well vascularized mostly, so they will not enhance as intensely as the tumors of malignant origin. Here I have got three-dimensional reconstructions from an examination obtained in a patient with amyloblastoma, and you can see that it's confirmed. Well, I'm telling you that this was confirmed by histopathology, but you can see that location is anterior mandible, so quite contrary to the typical location for the tumor, so expect the unexpected always. And another amyloblastoma and magnetic resonance imaging. So this type of imaging modality, it also allows demonstration of septa, so multiple loculations, compartments of this tumor. But still, as for now, histopathology is mandatory. The unicystic amyloblastoma, unfortunately, is very tricky because it can look like anything else, and this was also verified by histopathology. But in fact, if I looked at it just to report, I think that first thing first, I would have reported here an odontogenic keratocyst. And also in this case, I would think first odontogenic keratocyst because it's just more common than amyloblastoma, and also this lesion is unilocular, unicystic, without septa, so not very characteristic in fact. So, and the tumors require follow-up because they have a tendency of relapse. So here's a cone beam CT that was taken because of a follow-up in the case with a well-limited area where the tumor was excised, so no relapse in this patient. Differential diagnosis includes not only odontogenic keratocyst, but also a dentigerous cyst, so in other words, follicular cyst. It's also lesions with internal septa, like giant cell granuloma, odontogenic myxoma, and also ossifying fibroma. So let's move on to the second tumor, which is calcifying epithelial odontogenic tumor. Another name for this tumor is Pinborg tumor, from a surname Pinborg. And it's a tumor also of middle-aged patients, less aggressive than amyloblastoma. And this kind of tumor, as the name goes, it produces some calcified structures inside. So this is more helpful in differentiation of this tumor from others. It's more common in the mandible than in the maxilla, most commonly in the premolar, molar region of the mandible. Half of the tumors can be associated with an unerupted or impacted tooth, so they may displace a developing tooth and prevent its eruption. It may have well-defined border with cortical rim. Internal aspect, when it's not mature, when it's immature, it contains just soft tissue, so it's radiolucent. But when radiopacities occur, then the tumor is just more atypical. So this was our case, an incidental finding, in fact, because there was investigation of a second premolar that was missing in the dental arch. So a periapical was taken, and it could not demonstrate the whole lesion, as the lesion is between the teeth, but also outside the range. And all you can see is just a little bit of the crown of this impacted premolar. So with this panoramic radiograph, it's much easier to observe the extent of the tumor, and also displacement of the tooth related to the tumor towards the lower border of the mandible. And this is medical CT obtained in this patient, so it demonstrates in a very straightforward way the calcifications inside the tumor. They are kind of amorphous, and the tumor also produces large extension of the bone of mandible in buccal lingual direction. Here's another example of calcifying odontogenic tumor, and one more also, like in the previous case, related to impacted premolar. So I think that this kind of lesion should be a little bit easier for you to be diagnosed and differentiated. And also this one, and this is CT, so it also presents the internal calcifications in the tumor. So this is also medical CT, and also well visible lesion in the mandible on the left side in the coronary. So for differential diagnosis, until the lesions are calcified, well, they have to be differentiated from many other radiolucent lesions. But in case of radiopaque lesions, it's lesions like calcifying odontogenic cyst, it's ameloblastic fibroodontoma, and it's also adenomatoid odontogenic tumor. Now, I told you about hamartoma. So hamartoma is somewhere between a tumor, a neoplasm, and a developmental malformation, because in case of odontoma, there's no potential of growth. So once the lesion is formed, it stays the same, so it does not grow anymore. And these tumor-like malformations, they occur not only in the mandible. You can find them, for example, in the ovary in the females, and they can be found as teratoma also in, for example, floor of the oral cavity. So there are different variants of these hamartomas. And odontoma consists of calcified material inside the tumor, which is surrounded by a fibrous capsule. And of course, in radiography, you are not able to see the capsule itself. So what we can see is the presence of the capsule. So a radiolucent rim, a radiolucent band around the capsule. So the lesions are encountered in different ages, but mostly around the age of eruption of permanent dentition, because this is, on one hand, this is the time for the lesion for orthodontic, for example, treatment. So the patients have panoramic radiographs due to orthodontic indications, but it's also the age of observation of delay of eruption of some teeth, and when primary teeth are still present in the dental arch, it makes a doctor search for the reason why the tooth is not visible in the dental arch. And then they request radiography. And we have got two types of odontoma, compound and complex. So the compound, it's consists of several individual odontoids, and these are structures that resemble individual soft teeth, small teeth. And complex, it's predominantly an amorphous radiopacity, and it includes mixed tissues, mostly enamel. But anyway, this is the only tumor which is made of all three types of tissues forming the tooth. So, in fact, when you see an odontoma, it's going to be quite characteristic. So if you are to observe a tiny incorrect teeth surrounded by a capsule and surrounded by a sclerotic rim, then, well, with a large potential, with a high probability, you can say that this is an odontoma, which is in a way good news for the patient because it's always benign. So this is another example, a very typical compound odontoma, and this compound odontoma, it's made of these small teeth. Sometimes it's maybe difficult to differentiate an odontoma from a lot of super tiny supernumerary teeth. But this also happens, in medicine everything happens. But if you have a lot of these tiny incorrect teeth, then it's they will not be surrounded by a common capsule, so they will be located in the bone without some definite border, like in case of this tumor of odontoma. So in complex odontoma, the tissues are completely mixed between themselves, and they form a kind of a very densely calcified mass that you can see here in the circle. And here's another complex odontoma. So, as mentioned, these lesions are pretty frequent, and they are quite easy to be recognized. And of course, there's no reason for anxiety of the patient, because this will not grow, and this will not turn into a malignancy. But of course, in many cases, it requires excision, surgical removal. Odontogenic myxoma is a painless swelling or incidental finding when small. It's around 2/3 in the mandible. It occurs in the 2nd to 4th decade of life, but there's a wide range of age for occurrence of an odontogenic myxoma. And it's a radiolucency, radiologically speaking, unilocular, scalloped, or multilocular. the border may be well defined and corticated, or not so well defined and sclerotic. It may expand the bone, but this bone expansion usually is not very prominent, and tooth displacement or tooth resorption may occur. So in general, we say that myxoma has this honeycomb appearance because of many tiny compartments, many tiny loculations, and the septa in a myxoma will be more straight and a little bit more coarse, thicker than in case of ameloblastoma. Now there's also odontogenic myxoma, so in this case you can definitely appreciate the septa that are straight and they cross at more or less straight angles in many cases. There's odontogenic myxoma in bone window in CT, which is very much like cone beam CT. And we'll also talk about cementoblastoma, and benign cementoblastoma is in fact the only tumor which is made of the cementum. There is no other tumor that is composed of cementum of the roots, and this makes the tumor quite characteristic. Of course, it doesn't mean that it does not require differential diagnosis, but the typical location for the tumor that it's fixed at the apex of a tooth, and the tooth related to cementoblastoma is usually lower premolar. And what makes this tumor different from others is that the tooth usually produces pain. So the patients are symptomatic, and if a tumor is not correctly diagnosed, then the teeth will be treated by endo, and it will not help the patient to resolve the problem. Because the tumor will just keep on growing. And they are found more commonly in the mandible than in the maxilla. And characteristic appearance, it's well-defined radiopacity. Well, the radiopacity is a little bit less dense than radiopacity of dentine. Because normally the cementum is a little bit less dense than the dentine. And in case of multiple layers, accumulations of cementum and hypercementosis, and also accumulation of this incorrect cementum in case of cementoblastoma, then it will be visible. One of the symptoms reported for cementoblastoma, it's golf ball appearance. I don't know if anyone here plays golf. I don't know, but hopefully everybody knows what a golf ball looks like. And a golf ball is just white, round, and hard. So if you see a golf ball attached to a root apex, then think cementoblastoma. Of course, it also requires some differential diagnosis. So this was a cementoblastoma, and here the cementoblastoma in mixed stage with some calcifications and radiolucent rim, and this one is like this golf ball because it's very dense, it's very radiopaque, and it's also roundish. Well, maybe not ideal like a golf ball, but more or less like that. And here you have got another cementoblastoma. As for ossifying fibroma, It's radiolucent or radiopaque or mixed, and about half of the cases are radiolucent. It's usually well defined, but maybe multilocular, and it may also expand the bone. It's a tumor of young people, second to fourth decades, with some juvenile patients as well. So this kind of tumor, of course, has to be also differentiated from the Pindborg tumor, so the calcifying epithelial tumor. Okay, so this was the first part of our talk today. I'm sorry, there's something. I hope you can still hear me. So now we will switch to the second presentation, and the second presentation is about malignant tumors. So just let me stop sharing the other one, and let me share the malignancies for you. Okay. So now I'm going back to the desired window, and I hope I will be sharing the correct presentation right now. I think it should be visible. So for malignant tumors, they have different properties than the benign tumors because they also produce uncontrolled growth of tissues, but they are locally invasive, and they have ability to metastasize to regional lymph nodes or to other distant sites. So the role of diagnostic imaging is to verify not only the local extent of a tumor, but also the spread of a tumor to lymph nodes and to the surrounding tissues and the distant sites of metastasis. And the location is also very different, but the most frequent tumor that you are going to encounter in the oral cavity, it will be squamous cell carcinoma. So carcinoma, epithelial malignant tumor that can arise practically everywhere in the oral cavity, and nowadays we observe increase of prevalence of such tumors in young males. So this is being related to the infection with human papilloma virus. And there are also tumors that are not carcinoma, like sarcoma. And sarcomas, they also occur in specific locations. For example, chondrosarcoma occurs in the areas where cartilage is, like the condyle of the mandible, and we can also observe, for example, synovial sarcoma. So synovial means that it's related to the joint because of synovial line. The tumors, malignant tumors, they also have some characteristic features. If they grow in a young patient in a tooth germ, they may promote earlier exfoliation of such tooth germ, and their typical appearance is ill-defined. So they grow aggressively, so the organism doesn't produce cortical rim around such tumor. Of course, I'm always saying, usually because you never know to be true. And there is no capsule for such a tumor. And there is, if you see bone destruction and also the shadow of soft tissue tumor, it's highly suggestive of malignancy. The lesion can grow from maxilla into the maxillary sinus, can destroy the floor of maxillary sinus, and against the air in the sinus, it may look like radiopacity, which is a matter of contrast, and I think I have already explained it to you regarding the cysts, extrinsic cysts in maxillary sinuses last week. Most malignancies do not produce bone, like carcinoma. It doesn't, but sarcomas, they do produce some incorrect ossifications inside. And some tumors, like metastasis, for example, from prostate gland in males, they are osteoblastic, osteosclerotic, which means that they stimulate production of the bone. The tumor leads to loss of bone support for the teeth. So the teeth are described as floating in space. Floating in space. And the tumors mostly destroy the cortical boundaries, like inferior cortex, the floor of maxillary sinus, follicular cortices in people and children, and also the boundaries of mandibular nerve canal. And they grow very rapidly, and unfortunately, the tumors of the head and neck, they have a nasty property of a so-called perineural spread. So it means that they infiltrate nerves, and that's quite a lot of cranial nerves around the head and neck. So the tumors use them as a kind of a highway to hell, because the local extent of a tumor may not be so very pronounced, but then the tumor follows the sheaths of nerves, and they skip a direct invasion, and they grow as tumors also inside the brain, the cranium. And they also produce periosteal bone reactions, some of them. I have already highlighted the issue of this, of periosteal new bone formation in our first meeting on general symptomatology of head and neck examinations. So most of the tumors you're going to observe, so carcinomas, they will not produce any periosteal new bone formation. So the destruction will be visible as ill-defined area of bone destruction without anything appearing around. Then we've got laminated periosteal new bone formation with that we talked about regarding inflammations, but unfortunately in some tumors, malignant tumors like Ewing sarcoma, also this laminated, this onion skin appearance, onion peel appearance can be observed. So this is not reserved only for inflammations. And finally, we have got two types of periosteal new bone reaction, new bone formation, that should be like a red flag for you. One of this is destruction of cortical bone with periosteal reaction at the periphery. forming the so-called Convance triangle. And then there are spiculated sun-ray type periosteal bone formations. And some lesions produce these straight spikes, and they are also called sunburst. And so the squamous cell carcinoma is the most prevalent of malignant tumors of the head and neck. And in this kind of a cancer, it's radiolucency, it's bone invasion, it's soft tissue mass, and it can be found in different parts of oral cavity. What's important, of course, you don't have to learn this by heart, but you need to know for me here in radiology, but also for maxillofacial surgery in the future, that there is something which is called TNM classification. So T stands for tumor, and N stands for nodes, and M stands for metastasis. So these classifications are extremely useful for clinicians because they have different approaches to treatment of different tumors based on the degree of advancement of a process. So this TNM classification serves as a means of decision on the extent of a tumor. So, of course, don't learn this by heart. Nobody does, because these classifications keep on changing. So they can be found also in special applications for radiologists. So what's important to know that tumors are evaluated locally regarding the size of a tumor, then the presence or absence of metastasis to regional or lymph nodes, and then it's also for the distant metastasis. So metastasis 0 or metastasis 1. So if there's any, in case of oral cancer, if there's any metastasis to, for example, liver, lungs, etc. So any size of the tumor, it's not important. It's directly the T4C stage, so most advanced stage. And in the radiographs, it's radiolucencies which are ill-defined. In this periapical, of course, you can't see the whole extent of the tumor. And here is an example of this tooth floating in space. So the arrows point out to fairly well limited, but radiolucency, so the area of bone destruction. And in this area, the tooth has practically lost its bone support. And this is occlusal radiograph. And this is panoramic. So in panoramics, you have to look for ill-defined areas of osteolysis. And there is a tumor invading maxillary sinus, nasal cavity, growing into the soft tissues and destroying the heart pellets. So there's also examples of cancer. And this is panoramic radiograph with ill-defined radiolucency in the mandible, some remnants of roots. And in any of these cases, you have to remember that what you can see as the infiltration of a bone, most probably is just the top of an iceberg, and there is much more to be seen as infiltration in soft tissues, just like in this patient. So this is bone destruction. This is the extent of soft tissue lesion. Same here. So this is a CT, the destruction of a bone in the anterior mandible, and there is a very large lesion in soft tissues, enhancing mostly on the periphery with no enhancement inside, corresponding to necrosis. So we've got a lot of cases, unfortunately, of squamous cell carcinoma. And here's medical CT and panoramic radiographs. Maybe I'll come back here. So this is bone destruction and this is soft tissue tumor. So definitely the tumor is much bigger than the lesion in the bone itself. So this is a specific type of carcinoma. This is called carcinoma basocellulare, which means basal cell carcinoma made of different cells and different biology of the tumor, because although it's aggressive, it never produces metastasis, distant metastasis, but on the other hand, if not treated, it leads to very pronounced ulceration, like in this case with very big destruction of the maxillofacial area on the left. So there is no cheek, there is no zygomatic bone, there is no zygomatic arch, there's just like one huge ulcer under the eyeball. And radiographs and other diagnostic imaging methods, they may also serve as the means of verification of the lesions relapsing after surgery and treatments. Like in this case, there's relapse, and it's also metastatic lymph nodes with necrosis. All right, so the next tumor from the malignancies, it's osteosarcoma, and this tumor directly produces abnormal bone or osteoid tumor cells, and it's usually in exoskeleton, but 5 to 10% of these lesions, they may be found also in the head and neck, mostly in the jaw. And the tumor may produce pain, it may produce mental nerve paresthesia when infiltrating the nerve. The peak of occurrence of a tumor is around 4th decade of life, and they also grow very aggressively. So there's component of soft tissue lesion. They are radiolucent, but more commonly they are radiolucencies in the areas of bone destruction, and there's also new bone production of new incorrect bone, of course. The destruction of a bone is ill-defined, and this tumor is related to this sunburst, sun ray appearance. So these spikes that are more or less perpendicular to the surface of the bone. And also diagnostic imaging studies like MRI can be used for evaluation of these tumors. So they demonstrate a highly aggressive heterogeneous mass with the variable degree of contrast enhancement. So there's osteosarcoma in CT. There's huge tumor producing incorrect abnormal bone products, and the tumor is growing also, as you can see, into the orbit. So very huge tumor into the nostrils, in the nasal cavity, in the nasopharynx, and also destroying with bony walls of a maxilla. So if you see soft tissue mass, so radiopacity of sinus with bone destruction, then you must think about tumor of malignant tumor of maxillary sinus. So once again, the lack of proportion between the size of infiltration in the bone and size of the tumor itself. So that's this sun ray appearance, the sunburst appearance. And there's also an osteosarcoma. So here you can see some photographs and images from CT and MRI from the same patient. So as a result of infiltration of a tumor, the patient had to be operated on with large extent of this surgery, and as you can see, the patient lost an eyeball, and then you can see, and as it's called epithesis, so it's not prosthesis, but this is epithesis, and this is worn by the patient to as a kind of a camouflage of his missing eyeball. So here's another example of a sunburst appearance, and once again the tumor is much bigger than the bone destruction itself. Very heterogeneous tumor with intense contrast enhancement. So the next sarcoma I would like to show you, it's chondrosarcoma. It's also malignant tumor, a little bit less aggressive than osteosarcoma, so with such properties, a little bit better prognosis for the patient, but just a little bit better. And this is wide variation of clinical features, but also aggressive growth of the tumor and less frequent metastatic reaction of this tumor, so a little bit better long-term prognosis for the patient. But if you ask me how to differentiate an osteosarcoma from chondrosarcoma in plain radiography, well, I can tell you that when I was a young radiologist, more than 20 years ago, I attended one of the courses for residents in another city in Poland, in Kielce, and there was a professor who at that time was the head of a radiology department in the oncological center in Warsaw, and she has been talking for more than half an hour about just chondrosarcoma and osteosarcoma. And after the lecture, one brave resident asked her a question, but well, professor, please tell us how to differentiate osteosarcoma from chondrosarcoma. And she just sighed and she said something like that, well, you need 20 years to that, 20 years of looking at these tumors. So I think, again, what's the most important for you is to be able to pick up the presence of this tumor. And in this lady, she was, she was really lucky because despite the extent of the surgery, she survived. So this is a follow-up 5 years after surgery. So here you can also have a look at sunburst appearance together with soft tissue tumor. And this was our patient who had been, a very patient patient. I mean, when something started to grow in his face, he just decided to move out from the house and wait until it grows. So it was very malignant tumor, but it did not metastasize. And Ewing sarcoma, it's very tricky. It's not very common, but it's very tricky because both clinically and radiologically it may mimic osteomyelitis. So last week we were talking about osteomyelitis, and it's a tumor, mostly a tumor of children, and because of this clinical appearance, it can be mistaken for inflammation and at first incorrectly treated with just antibiotics. The tumor produces soft tissue mass, the bone is destroyed, and it's so-called moth-eaten pattern of bone destruction, so pretty much like what I was explaining to you last week. It can also produce this periosteal new bone in the onion skin, onion peel. So again, pretty much like osteomyelitis. And there is a child, so there's sunburst appearance and a tumor. There's huge tumor, so expansion of the mandible with sunburst appearance. And we've got a lot of tumors that grow from incorrect production of blood cells, so hematopoietic tissues. And here's something that's called non-Hodgkin's lymphoma. Non-Hodgkin lymphoma involves lymph nodes, but it can be found also in some extranodal signs. It's all age groups, but there's one type which is called Burkitt's lymphoma, which affects mostly children, so not adults. And it's a soft tissue mass which is radiolucent. It does not produce any bone, it does not produce any periosteal new bone formation. It may look like necrotic lymph nodes, so definitely it's more diagnostic imaging required to make a diagnosis of non-Hodgkin's lymphoma than just plain X-ray. So it's also a tumor of maxillary sinus growing out into the cheek. So here was also an example of non-Hodgkin's lymphoma with ill-defined bone destruction without predominant new bone formation. And there's also a soft tissue tumor, so you can see the difference between the size of a tumor in soft tissues and what you can observe in the clinical picture. Sorry, there's a sip of tea. And in magnetic resonance imaging, this tissue tumor around the teeth that are not resorbed. So a young patient with bilateral appearance of non-Hodgkin's lymphoma, not only in maxilla, but also in the mandible. So there's bone destruction, but the arrows point out to the margins of soft tissue tumor in the malignant non-Hodgkin's lymphoma. Myeloma, this is very interesting, and I think that you should remember this one definitely, because this is a tumor derived from plasma cells of bone marrow. So the lesions are usually multiple. However, a single plasmacytoma, so a single site of plasmacytoma as a radiolucency is also possible, but with time, if not treated, it will turn to a plasmacytoma with multiple locations. And the lesions is the most common primary malignancy of bone in adults, of course, and more frequent in males than in females, encountered around 50 years of age and above that age limit, and this is a tumor that produces bone pain, and here it says bone jaw involvement seldom, but we do have some cases. But again, it's probably because in our center the patients are referred for treatment of more complex lesions. And the appearance in this case, at least, is quite characteristic for multiple lesions. It's multiple radiolucencies. They are called punched out. So what does it mean, punched out? Like you've got a puncher with device for making holes in sheets of paper in an office. So you just if you just see holes in the bone that look punched out, think myeloma or plasmacytoma, as it's called nowadays. And it used to be called multiple myeloma because the lesions are numerous, they are multiple. And when you evaluate the myeloma, then please take into consideration that it can affect also the skull vault. So here's multiple lesions in the bone of the mandible, but also in the frontal bone bilaterally. So these are these punched out lesions. And the solitary lesion, solitary plasmacytoma, may not be very specific. Then there's an issue of metastatic disease, and the metastasis can be found also in the jaws. Like with everything that involves bone marrow, mandible will be more affected than maxilla, because in mandible you just have more bone marrow. And we always say metastasis, but it can be one metastatic tumor, so it doesn't mean that you need to have multiple lesions in order to be able to diagnose a metastasis. So in the bone, it's rather ill-defined, not corrugated, not encapsulated, and the tumors that promote bone formation, it's mostly prostate gland cancer, and they are osteoblastic, they stimulate bone formation. And as far as breast cancer is concerned, it's mixed. It's osteolytic and osteoblastic. And most of metastasis, it's osteolytic. And the metastasis, they efface lamina dura of the teeth. They can cause irregular increase in the width of periodontal ligament space. If they affect the papilla of developing tooth, then the cortices of the crypt may be completely effaced. And there's also this teeth in the floating in the space appearance. Extraction sockets fail to heal, and there's also destruction of the outer cortex. So metastasis can be found also in the lymph nodes. So as you can see here from the diagram, we've got a lot of lymph nodes in the head and neck. Here you can find them by anatomical names, but the lymph nodes in the head and neck have been grouped according to the levels, as it's called. And when you get a report from a radiologist, then in this report you will read, for example, level 1B lymph nodes, level 3 lymph nodes. So it's useful to know which level is which. So here you can see that there are 6 levels of lymph nodes, And level 1, it's submental and submandibular lymph nodes. They are under the border of a mandible all the way to the angle of the mandible, and they are divided into 1A, 1B by anterior belly of the digastric muscle. The level 2, it's upper jugular nodes, so they are posterior to the ramus of the mandible, but anterior to the sternocleidomastoid muscle. Level 3, it's mid-jugular nodes, so again, anterior to sternocleidomastoid muscle, but it's between the level of the hyoid bone here and the level of cricoid cartilage of trachea, or also the omohyoid muscle. And number 4, it's supraclavicular nodes. Number 5, under the sternocleidomastoid muscle, it's level 5, 5A and 5B, so posterior triangle nodes. And 6, it's paratracheal nodes in front in the midline. So these ones are the lymph nodes for the spread, for the regional spread of different neoplasms with the lymph as metastatic cells into the lymph nodes. So for the oral cancer, we are mostly preoccupied with 1A and 1B levels as they drain the lip, the oral cavity, and the skin of lower face. In fact, there's still no ideal method that allows differentiation of a lymph node, a metastatic lymph node from another type of lymph node. And here you've got the Salviati index. So the Salviati index is the longitudinal transverse ratio of axis of a lymph node. So if it's above 2, so the lymph node is more oval, more longitudinal, it's more probable that the lymph node is not metastatic. But the lymph nodes that are roundish, not fusiform, so the Salviati index is below 2, they are more suspected of spread of metastasis. So the lymph nodes that are reactive, so enlarged because of inflammation, and they will be usually hypoechoic. And in case of metastatic lymph nodes, they can be hypoechoic, but they can be also echoic inside. They can be also heterogeneous. So here you can see sonographic feature of a cervical lymph nodes, which are kind of normal here as fusiform with cortex, which is hypoechoic, and then the center, the hilum of the node is of higher echogenicity. And in a metastatic lymph node, it's heterogeneous appearance, anechoic patterns with loss of the hilum. Okay, so that's pretty much all I wanted to tell you tonight. So have a nice week, and I will see you same place, same time next Monday for the next